goes through a comparison of the House and Senate provisions, including how they're financed. Let me just go over briefly how they're financed. Both of them, about half of it comes from savings in Medicaid and Medicare, principally reductions in the overpayments of the Medicare Advantage companies. Both of them do that. They both reduce DISH payments, the disproportionate share that goes to hospitals for treating Medicaid patients. They both do payment reforms and fraud and abuse. And then they diverge pretty significantly. The House places a surtax on people earning more than $250,000 a year. The Senate taxes what they call Cadillac plans or high-use plans. All insurance products that are sold in a group plan are exempted from from income tax. So anything I get from my employer is not considered taxable income. And they would take very high expensive tax the insurance companies that provide high-end insurance companies at 40%. Fred will eloquently point out that there's a mechanism in there that doesn't adequately call for rate of inflation, and so it may reach middle-income people much sooner than any of us would like. But those are those two basic outline of funding mechanisms.
Fred, Perry's right. That mechanism is in place, but where it sits level today, that will not hit a significant percentage of the employer claims that are there. But it only allows an inflationary factor of consumer price index plus 1%, whereas medical inflation has typically run close to double that. So that if you look forward to 2016, 2019, beyond, then you have a much more significant percentage of those plans to be subject to that tax, or the consequence will be that the benefits available under those plans will be further reduced to avoid the tax. There's also in the Senate bill a proposed tax on the insurance market, which is based on their share of the market, regardless of whether they're profitable or not profitable. It's a flat tax across that. And one of the areas that there's really a big uncertainty in the numbers you see now, where even in the Senate bill, where they say it's going to cost $892 billion over 10 years, and the revenues that are associated with that and the overall savings, and where it's not going to increase the deficit. I think an important factor to point out there, they're talking about 10 years worth of revenue to offset 7 years worth of costs because of the fact that the plans don't go into effect for several years down the road. So they're measuring 7 years of implementation versus 10 years of revenues. Some people in the Senate are now asking for a 20-year estimate from the Congressional Budget Office, not a 10-year. And it's going to be very interesting to see what those numbers spell out, to see if that's really going to flip the equation on that, and whether they're going to have to go back to the drawing board to try to find additional savings.
Well, I would say that the other panelists have adequately addressed how the proposals are going to pay for themselves or be paid for. What I would suggest is what I think Fred said earlier, and that is that we do know the current system is not sustainable as it is, and that there's a cost associated with doing nothing.
One example to demonstrate savings is that approximately 70% of all emergency room visits are non-emergent. And if we can shift those emergency room visits back to the primary care level, there'll be significant savings in the overall system. Of course, as we start pushing people into primary care, that initial few years cost is going to go up, but it will level off over time. So the emphasis on prevention and improvement into primary care will be one avenue. As I indicated earlier, the community health centers nationally, the analysis that was just recently completed indicated the savings of $212 billion over the 10-year period. The reason that they can do that is because they provide the comprehensive primary care services, and part of that is that care management for chronic disease, and will keep those people out of the hospital more frequently.
Thank you, Louise. Yes, another statement or question, please?
Yes, I have a question I'd like to direct to Mr. Earley. While I support maintenance of the private insurance system, I also support a public option. And some of my more conservative family and friends don't feel like the public option can go hand in hand with maintaining the private insurance is. Do you believe, speaking from the insurance industry, private insurance industry perspective, that if a public option is held to the same standards, the same reimbursement rates, and is not subsidized by the federal government, that the private insurance industry can maintain itself and will be viable long term.
It's an interesting question when you ask whether the public plan is not going to act like a public plan, and which would raise the question if it's not going to act like a public plan, that is, it's not going to set rates that aren't market driven, or it's not going to it's going to have to follow the actuarial guidelines and principles that private insurers are, and maintain reserves, and do funding, and do all the things that private insurers are going to do. Then the question really is, why do you need a public plan? Because then it's just going to act like the rest of the market. The only way that the public plan is viable is the fact that it's going to mandate prices that are below what can be set in the open market. And a case in point for that right now, Mountain State operates a plan called the West Virginia Small Business Plan. It's available for small employers in West Virginia that have not had health insurance coverage for their employees for at least a year. It's basically for startup businesses. It's marginally effective. It has roughly about 1,700 individuals that are covered under typical size of the group is 2 or 3 employees. It pays off the PEIA rate schedule. And that's a rate schedule that what they pay hospitals, what they pay doctors, they set every year. They don't negotiate rates. They say, this is what we're going to pay you. This is what we can afford to pay you. It's about 25% lower premiums than what we can do on the open market with the best rates we can negotiate, because government doesn't negotiate rates, government sets rates, and they're not adequate reimbursement, and that cost is shifted over to the private sector. Our concern would be, once you get down that road with a public plan, and they see that they can't compete, and they can't do it as well as private sector, then they'll go back and cut the rates and set pricing that is not market driven and therefore create those inequities. I've not ever seen a model where you show me where a government system competes effectively and evenly with the private sector market. I've just never seen it. I'd like to see some examples. I just haven't seen it.
Can I follow up?
Sure.
Maybe I'm one of the hopefuls that believe that it could compete under the premise of more efficient, streamlined system. You look at some countries around the world, I'm going to take Taiwan, for example, it has 6% overhead administrative costs compared to roughly 20 to 25% in the private industry in the United States, which private industry typically associated with cost effectiveness, streamlined efficiency. And we haven't seen that in the private industry. And I think we could see that. If you look at Medicaid, Medicare, I believe the overhead is somewhere around 2%. And I think that that's where the savings, at least some people, this is how I see it, would come from in a public option, that you're paying the reimbursement at the same rates, they're just doing it more efficiently.
We'll try to address that. I would, and I don't want to be debated about it, I would challenge the 2% Medicare because that really doesn't take into effect what they're paying to the intermediaries to administer that, but there's benefits. Plus, they don't do the things that are required of us from the insurance industry in terms of what we do to provide care management, disease management, and some of the other programs and protocols that we're required to do under our current regulatory structure. It really is comparing apples and watermelons to some degree because there is vast differences in terms of how Medicare operates and how they would have to operate if they want to compete in the open market, have to negotiate prices, have to establish networks, have to maintain networks, have to develop their own reimbursement systems, their own medical policies, and the methodologies which would be required for them to compete in the private sector economy. But one other point I'd like to follow up on that, and are there things we could be more efficient on? There's no question. But I think every avenue of the healthcare delivery system really needs to take that look themselves. Hospitals, physicians. I mean, you've heard a lot of comments today about the for-profit health insurance system. And I would challenge to say that there's nothing wrong with companies being profitable.